Thank you, Vicky. It's really a pleasure to be here. Unfortunately, we can't be in Portugal right now, but you have my warmest greetings from Athens. It is my pleasure to share with you the revisitation of an old technique, which is not the favorite between surgeons and patients due to its healing pattern. And I'm speaking about photorefractive keratectomy or surface ablation, and I do have financial interests, but none of those relies to this presentation. So for Alcon and Orca that make these instruments, but this was a study we initiated in our center. And in essence, what we tried to do is we tried to bypass some of the disadvantages with PRK. And why would we do PRK in a practice that, and I've advocated through the years, is mainly a lamellar procedure practice? This is an example of a case where we feel in the Pentagram maps that the cornea thickness is shallowing abruptly. And living and practicing in a country where 1 out of 20 people has keratoconus, we can also see this in the OCT thickness maps. We opted in this patient to go with PRK. So in this study, we looked at a large case series that the only thing we changed from my classic PRK protocol is that we used the EBK Orca device to deepithelialize the cornea, but only the diameter of cornea that was necessary for the ablations. So there was a lot of back and forth between the treatment laser computer, the X500 excimer laser, and the cornea prior to beginning the procedure to denude only a 6.5 to 7 millimeter disc from the central cornea with the EBK device. Obviously, if astigmatism was involved in these myopic patients, it was an oval denudation of the epithelium. So there is a little bit of a learning curve here, and you can't always, with this device, get the exact deepithelialization that you opt to. And this is a short video of the procedure. The device, if you're trying to do this, seems a little bit bulky. So you'll see me reorienting my hand. It gets a little difficult in left eye because I'm right-handed. But you can clearly see that this is way different than using diluted alcohol or using the very popular the last few years transepithelial approach that removes 8 to 9 millimeters of cornea epithelium. We're looking here at a very small amount of cornea epithelium being removed, and I think we'll agree to that. The trick here is you have to make sure that you see the shiny, polished surface of Bowman's because you may leave an island of epithelium behind that will interfere with the ablation. So in essence, we looked at pain scores, which is the most important thing here. And the astounding numbers were that the eyes that had the mini PRK greatly outperformed the eyes that remove the epithelium with a transepithelial approach or with diluted alcohol deepithelialization. The second remarkable thing was that 95% of these eyes were re-epithelialized by day 3. And I want to underline that we're seeing some images on the right-hand side here of completely re-epithelialized corneas on day 3. Another caveat here is that all of the eyes were at least 20/25 when a patient walked off the laser room. And this is very different for PRK, at least in my experience, the PRK that I have been practicing all these years. And I'll show you, fine, this is an example here on the bottom right where one eye has fully epithelialized, the other one, you can see there's still a central island that's that has not epithelialized, and obviously this eye falls into that 5% that took 4 days to reepithelialize. No eyes had epithelial defect by day 5. So at 3 months, visual acuities are absolutely comparable to our topography-guided LASIK eyes. And of course, there is a restriction in PRK, especially in Southern Europe, that we need to protect the eyes from UV light for at least 6 weeks. This is a little tricky in the winter. Greeks are not used to wearing sunglasses in the winter, so we have to work on that. But I think that we're up to something very interesting here. In conclusion, that by using this technique, we make patients very happy because this becomes a very seamless procedure, very LASIK or SMILE-like procedure. And not every eye is made for lamellar refractive procedure. And the data appears superior to LASIK and SMILE. If you look just the post-op, the immediate post-op vision, of course, the day 2 and day 3, there's a little bit drop in visual acuity. But I think that this is a suggestion and an option for eyes that are not apt for LASIK or SMILE to have a safe and very rapid and recovery procedure. Thanks very much for your attention.
Thank you, Tassos. Please stick around for the end of the session for the discussion. I would like to welcome my co-chair, Professor Dr. Paolo Vitguera,